one of our regional perinatal center educators and coordinators that is going to be speaking for us. Her name is Tonia Russell. And just to give you a little bit of a background, Tonia Russell is an RNC and in EFM. She graduated from UGA in '94 with a Bachelor of Science in Pre-Med Cellular Biology. And after 10 years in corporate America, she returned to her true love of nursing in healthcare. And she went back to school to further her education and got a nursing degree from Columbus Technical College in 2004 and started working immediately as a perinatal nurse. In 2011, she had an unexpected offer and was able to transition from a perinatal nurse to the maternal outreach and transport coordinator for Piedmont Columbus Regional as part of the Georgia Perinatal Regionalization System. So utilizing her client experience, HIV/AIDS, public health volunteer work and education, and her nursing knowledge in perinatal care for women and infants, Tonia now educates nurses and physicians by practicing in the hospitals within the 21-county region of West Central Georgia. She teaches evidence-based perinatal nursing education, focusing on simulation training and interactive classroom teaching. Tonia is certified through EFM through the National Certification Corporation, and she uses this expertise as an A1 instructor for both the intermediate and the advanced electronic fetal monitoring courses. Tonia's commitment to improving birth outcomes lead her to develop programs in HIV/AIDS testing during the 3rd trimester of pregnancy, as well as a comprehensive perinatal mood disorders program focusing on early diagnosis and intervention. Tonia is nationally published for both programs, so we are delighted to welcome Tonia. Thank you, Tonia.
Thank you, Lauren. I would like to thank both the Georgia Perinatal Quality Collaborative and the Georgia Department of Public Health for asking me to present today. So we'll just go ahead and get started, and I believe after the presentation there may be a few moments for us to go over any questions that you guys might have. So I would like to go ahead and provide a disclosure for everyone. I have no conflicts of interest, no endorsements or financial relationships to present, so my endorsement. We do have 5 objectives that we will cover today, so after the presentation you should be able to speak to any one of these 5 objectives. We will identify the components of the hemorrhage cart or kit, articulate the risk factors for hemorrhage, verbalize quantification of blood loss, explain the massive transfusion protocol, and discuss the process of simulation drill for hemorrhage management. Grace, next. Today we are discussing the Alliance for Innovation on Maternal Health and the Georgia Perinatal Quality Collaborative Patient Safety Bundle for Obstetric Hemorrhage. So what is an obstetrical hemorrhage? A hemorrhage is greater than 5,000 mLs total blood loss for a vaginal delivery, and for a cesarean delivery, anything greater than 1,000 milliliters of total blood volume. That is what constitutes a hemorrhage. So hemorrhage is the loss of blood before, during, or after a delivery resulting in medical emergency. Hemorrhage is one of the primary causes of maternal morbidity and mortality in the United States, and it is also one of the most preventable causes of maternal mortality. Common causes of obstetrical hemorrhage range from uterine atony, which affects 80% of hemorrhage cases and complicates 1 in 20 births, and it ranges from trauma and lacerations to incisions, instrument-assisted deliveries. Hemorrhage may also result from comorbidities such as hypertensive disorders, HELLP syndrome, obesity, multiple gestation, polyhydramnios, abnormal clotting factors, which can both be a cause and a result of hemorrhage, retained fragments of tissue from the placenta, or as a result of augmentation or induction of labor with exogenous oxytocin. As extensive as this may seem, it is not a complete list of factors that may result in an obstetrical hemorrhage. Next. So think about your unit, where you work. Does your hospital currently utilize safety bundles for the care and management of your patients? What is a safety bundle? In an effort to improve birth outcomes, hospitals across the nation have worked diligently to standardize care, ensuring the process used for managing an obstetrical hemorrhage, for instance, in Georgia, is the same as the process they use in California and Texas and Florida. AIM, we've mentioned AIM a few times. It is the Alliance for Innovation on Maternal Health. It is a multidisciplinary partnership funded by the Maternal and Child Health Bureau, Health Resources Service Administration, and is focused on standardizing obstetrical care for complications and is designed to improve patient outcomes. Next. So if you look at this map, you'll see states indicated in dark green. The green states indicate those currently participating in the AIM initiative. They are California, Florida, Georgia, Illinois, Louisiana, Maryland, Michigan, Mississippi, New Jersey, New York, North Carolina, Oklahoma, South Carolina, Tennessee, Texas, Utah, Virginia, and West Virginia. So we have several states that are participating in the AIM initiative, but we still have many more states that we would love to have participate. Next. Each AIM patient safety bundle consists of 4 separate components. Each component addresses a key element in the standardization of care in a structured and easily recognizable format. The specific areas of the bundle are readiness. Is your hospital prepared to care for this event? Are the necessary tools in place to effectively manage an obstetrical emergency? Recognition and prevention. Are you familiar with the risk factors associated with each complication? And are you able to glean the information from the prenatal records, patient history, physical assessment, and be able to identify women who may be at risk for adverse outcomes? Response. Does your hospital have established processes for managing the event and supporting their patient, their support system, and the involved hospital staff? And the final area, reporting and system learning. Does your unit consistently participate in a multidisciplinary debriefing following each and every event? In the past, debriefings had a negative connotation. However, a debriefing should never be viewed as a punitive step. This is an opportunity for the staff involved in caring for the patient to discuss what went well, what can be improved upon, and is also an outlet for the clinical staff to discuss how this event has impacted them. Next. So today we're actually going to focus on the first component of the obstetrical hemorrhage safety bundle, readiness. So remember, readiness is the preparation. Do we have all of the tools in place to successfully manage the hemorrhage event? As soon as an obstetrical hemorrhage has been identified, the clinician will call for additional help and the dedicated hemorrhage cart or kit. The cart is designed and stocked with the supplies and tools needed by the clinician and the obstetrical provider to effectively manage the patient's care while reducing the amount of time lost by waiting for individual items to be received by the team. Preferably, the cart will house the potential items that are needed for an obstetrical hemorrhage, but it may be tailored to meet the specific needs of each individual facility and unit. There are, however, certain items that must be present. If a physical space is a concern, the unit may opt for the tackle box, as mentioned earlier, that Terrell discussed. However, we do prefer a crash cart simply for the convenience and the ease of pushing a cart into a room versus grabbing the kit, the hemorrhage medications, larger supplies that may not fit in the kit, and the scale required to weigh items saturated with blood. So here you see a hemorrhage cart, and we are actually going to dissect the items that are in that cart. Okay. Grace, can you get to the next slide?
Sorry, it is. Oh, there we go.
It's thinking.
Sorry, it just wouldn't listen to me. Go ahead.
Oh, that's okay. So I know it's difficult to read this list, but if you just notice the number of items required, you can really see why a cart is preferred, because there are several things that may be needed. The specific items within the cart are going to be those items needed to start an intravenous line. So that would be tourniquets, alcohol prep, 18 gauge or larger IV catheters, IV tubing, tegaderm, tape for securing the line, along with liter bags of lactated ringer solution, hematology collection tubes, biohazard bags for the blood specimens, labels so we can do our bedside labeling. Other items include a urinary catheter with urometer, various clamps, retractors, forceps, laps, tamponade balloons, sterile gloves, and of course we've mentioned the scale, because we do need to be weighing all items that are saturated with blood. In most facilities, the medications that need to be pulled will be pulled out of a Pyxis type system, and they will be delivered with the cart. Some of the specific drugs that we use would be oxytocin. We need to have 20 units available. At least one ampule of Hemabate, and that's 250 micrograms per milliliter. Methergin, one ampule of 0.2 milligrams per milliliter. And Cytotec, 5 tablets of 200 milligram Cytotec. Next. So now that we have the supplies in our cart or our kit, we now need to locate policies, procedures, and guidelines for our unit. Are you familiar with your hospital's policy and or procedures for managing an obstetrical hemorrhage? When was the last time you looked at it? So does that policy, when you pull it, does it reflect current evidence-based practice? The California Maternal Quality Care Collaborative, the CMQCC, was at the forefront for establishing a standardized process for hemorrhage management. They set the bar, and I'm sure you've all heard the saying, there's no need to recreate the wheel. Well, the CMQCC did their due diligence, and they provided a comprehensive evidence-based process. A1, ACOG, and AIM adopted what the California Maternal Quality Care Collaborative did. So we encourage you, we need you to pull your hospital's policies and procedures and guidelines, review it, study it, learn it. You really need to know it. Next. So we've almost completed the readiness portion of the bundle, and we know during emergencies, one of the first things that we do is to call for additional help. When you call, do you know who's going to walk through that door? In some places, we don't. So who is going to be our response team? When we identify or a provider identifies a hemorrhage, who is going to show up? Who is part of that team? In addition to the bedside nurse and the charge nurse, we need to have the obstetrical provider. And in the instance where the provider is a midwife, the attending physician needs to be notified as well. Anesthesia, respiratory, ICU, possibly an emergency department physician or a general surgeon. And one of the most important components is going to be the blood bank. They all need to be involved. And you see, the patient is the center of that team. Next. Well, we've discussed what a hemorrhage is, but we also need to be aware that we no longer estimate blood loss. So if we can't estimate blood loss, how do we determine how much blood is too much, and how do we communicate that information to our response team? Since our ability to determine blood loss to even a close approximation is very, very poor, every hospital, every unit must quantify cumulative blood loss and provide the measured amount of blood in milliliters. This is where the scale comes into play. Every item containing blood and clots would be placed on the scale and weighed. Are we still there? Okay. So the total weight is identified by the dry total weights of each item subtracted out of the total weight. Many institutions place a card on the scale with the dry weights of any item that may become saturated by blood, and it gives you a little quick reminder of what you need to subtract out of the total weight. So an example would be when a patient starts to hemorrhage, she saturated 3 blue plastic chucks, and they weigh 10 grams each, and 1 cloth underpad that weighs 639 grams. The total weight, when we place everything on the scale, is 2,046 grams. Subtracting out the 669 grams for the total dry weight of the pad and the 3 chucks, what remains is 1,377 grams. That is the actual blood loss. Every gram of weight is equivalent to 1 milliliter of blood volume. We cannot stress enough, weigh all items. Remember, anything greater than 500 milliliters for vaginal delivery and greater than 1,000 milliliters for cesarean delivery constitutes an obstetrical hemorrhage. Also, blood loss is cumulative. So what was lost during the delivery would be added to any additional blood loss to provide the total loss. And you'll see there is a form on this slide, and I know it is very difficult to see, but it is the dry weight items of anything that can become saturated, so we can add everything up on one sheet and have it in a very compact, easily recognizable, identifiable format. Next. Okay. We now have our supplies, our policy procedures. We know who our response team is. We're quantifying blood loss to guide our treatment. They're all key components to successful management of the event. However, there's one component that still remains, the blood. During a hemorrhage, minutes matter, seconds matter. A woman can exsanguinate in as little as 8 to 10 minutes. Blood products must be infused quickly, and if the confirmatory ABO-RH typing is not available, what will be given is generally going to be O-negative red blood cells. If confirmatory typing confirms that the patient is positive RH typing, then the patient will be switched to O positive blood. However, if the patient is initially receiving O positive RBCs, then found later to have a negative RH component, they will not be switched. They will continue with the positive blood typing. So blood loss occurs very, very quickly, but the replacement needs to be done very quickly as well. Next. The process by which blood products are ordered, received, and administered is guided by what we call a massive transfusion protocol. Each facility should have a massive transfusion protocol in place. This is a flow diagram for the implementation of the massive transfusion protocol. When the massive transfusion protocol has been initiated by the provider has to be the one to initiate this. One clinician is designated to have contact with the blood bank. They contact them, let them know that the protocol is in effect. They are the ones that actually receive the blood products, and they are the ones to let the blood bank know that that process and that protocol is terminated. It eliminates cross different individuals, and it eliminates a lot of the confusion that may occur if there are multiple people trying to talk to the blood bank. So once the protocol begins, the blood bank is aware that this patient takes priority over every other patient in the facility. The blood bank will begin making coolers, and the coolers contain the packed red blood cells, plasma, and platelets. The first cooler that you receive is going to have 6 units of RBCs, 4 units of plasma, and 1 unit of platelets. And then the subsequent coolers will contain 6 units of packed red blood cells, 6 units of plasma, and 1 unit of platelets. Those coolers will be continued to be replaced, so they are readily available and waiting when you need the next cooler until the process and the protocol is terminated by the provider. Next. The Joint Commission actually issued Sentinel Event 30 back July 21st of 2004. So in 2004, the Joint Commission identified that we need to be conducting simulation-based training and event debriefings after emergencies. So this alert specifically addresses preventable death and injury during delivery, and the recommendation at that time by the Joint Commission was to focus on preparing for obstetrical emergencies, ensuring that the entire team could effectively provide care while functioning as a healthcare unit. For high-risk events such as shoulder dystocia, emergency cesarean deliveries, maternal hemorrhage, and neonatal resuscitation, clinical simulation drills are encouraged to help staff prepare for those events before they actually occur. Simulation-based training prepares the healthcare team for emergencies, and that preparation reduces morbidity and mortality. We also learn valuable debriefing skills which aid in continued improvement in process, management, communication, and outcomes. Next. Each piece plays a vital role in the readiness of successful management of obstetrical hemorrhage. We must have a hemorrhage cart or kit stocked with the essential supplies needed. We must have evidence-based policies, procedures, checklists supporting the treatment of a hemorrhage. We must have an established multidisciplinary team to provide specific care based upon their skills. We must quantify blood loss and provide a cumulative total volume to guide our treatment. We must initiate and institute a massive transfusion protocol that is recognized and followed by the hospital. We must establish simulation-based training so we can perfect our skills and improve outcomes. And we must follow up with debriefing with each person involved in the event. So each person involved in this hemorrhage needs to be present for this debriefing. It allows the team to identify those positives, the things that went right, areas that we can improve upon, and improve our overall effectiveness of teamwork and communication. Next. So that is the readiness component of the AIM initiative for obstetrical hemorrhage.
Thank you.